All right. Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network and the Lineberger Comprehensive Cancer Center. It's January 11th, and this is our UNC Cancer Network RN and Allied Health Lecture. A few preliminaries before we welcome our guest. If you need to email us with any problems that you're experiencing, questions, etc., unccn@unc.edu. If you need to call or text us, 919-445-1000, that number will work. We're going to use poll everywhere, and I'll talk about that in a minute. We'll use it for a question at the beginning and then for a question and answer at the end. You can check us out on the web at unccn.org, find a list of all of our events for the year and lots of other things as well. You can find us on Facebook, find us on Twitter, lots of ways to find out about our activities and the UNC Cancer Network. All right. This is what our poll will look like. And so what you do to kick this off is you just text the UNCCN to the number 22333. So you punch in 22333 and you put in the letters UNCCN. That activates poll everywhere. Then after that, you can just answer any poll. And when we get to the Q&A portion of the presentation, you can go ahead and submit your questions there. So for this first one, we've got most cancers are inherited. True or false. So if you believe that that's true, you can put in an A. If you believe that's false, you can put in a B. We'll see that in real time in just a minute, and then our guest can respond to that momentarily. All right. We have with us Julianne O'Daniel, and she is Director of Genetic Counseling at the UNC Clinical Program in Cancer and Adult Genetics, an associate member of the Lineberger Comprehensive Cancer Center, and an associate professor with the Department of Genetics at the University of North Carolina at Chapel Hill. As a researcher and genetic counselor, her work is centered on the practical applications of next-generation technologies, including the interpretation process, clinical applications, implementation, and essential support for patient and clinician use. And Julianne, welcome. We're glad to have you with us today.
Thank you.
Let's take a look at that poll, and we should start to see some results coming in just a moment. While that's coming in, it was interesting because this morning I was looking at TechCrunch, as I typically do in the morning, and there was a story about a company called Illumina that's promising within the near future to sequence your complete genome for about $100, they're saying. Wow. That's their target price. And so it was interesting. Then a little later this morning I was reading your bio, and I saw that same company name, and I went, wait a minute, is that Illumina? Is that the same company our guest is involved with? Do you mind telling us a little about that?
No, not at all. It was a fascinating opportunity where I'd been studying genome sequencing. And this was an opportunity. The company first started offering clinical whole genome sequencing, which was something that was unheard of just 10 years ago. And they first started developing it in about 2009. And I joined the company in 2010 to help them figure out how to offer that in a clinical medical setting.
Great.
And so there are obviously a lot of ethical concerns, a lot of kind of technical and biological concerns as part of that. It was fascinating. Got to speak with the scientists on the other end of the test results, which I really enjoyed because it helped me understand the patient side of it as well, to be able to explain to patients what those tests can tell us and what they can't at this point.
Right. Well, very good. It's unbelievable to think about that cost that they're targeting $100, given that that first complete sequence cost over $1 billion.
Exactly,
like
and that was in 2001. Okay, right around 2001 when they did the first draft of the human genome, and that was back with Bill Clinton was president when they announced that, and that was about $1 billion. You're right.
Wow.
And so when I was there in 2010, we were offering whole genome sequencing for about $100,000.
Wow.
So that should tell you a little bit about the scale of technology in the past few years.
Absolutely. That's great. Well, I know you've got a lot to talk about today. Looks like, I don't know if you want to say anything about our poll. We've got 11% saying true and 89% saying false.
That's a great number. So I go with the false.
All right.
Most are not hereditary in a single gene sense, but we can talk a little bit more about that. So the true are not completely off the mark either.
Okay. Good to know. Well, with that, I'll go ahead and turn this over to you and give you the
Thank
keyboard
you.
and the mouse. Absolutely.
All right. So thank you guys for listening in today. And I figured it would make sense to start with a clinical scenario that you may have seen or may be faced with. This is a 46-year-old patient comes to see you feeling as if she's destined to develop breast cancer. Her mother was diagnosed with breast cancer at age 65, her paternal grandmother at age 70, and recently her best friend at age 43. So what next? Okay, and I'm going to leave that one unanswered for now. Another scenario you might encounter is one of the clinic providers leaves a note at your workstation to, quote unquote, order the genetic test or call about how to order the genetic test for breast cancer. What in the world might they want? And so those are two of the questions I want to try to answer today. We're going to mostly focus on the hereditary cancer risk. And part of that is differentiating what we call hereditary or germline cancer risk from tumor testing, how to identify patients that might be at risk for hereditary cancer, what are some testing considerations, and what might be next steps if you have a patient that you're suspicious there could be something else going on. Okay, so to get to that polling question, all cancers are genetic on the cell level. Most are not inherited. And by that we mean most are you can't attribute to a single gene that's being passed down in a family. We in genetics love to say that everything is genetic. You could even say trauma and visits to the ER could be genetic based on other familial factors. And so personal and family history can definitely give us clues, and we're going to get into a little bit more about what that means. Okay, so cancer for most people we call complex or multifactorial, just as a fancy word saying there's multiple factors. If this were our scale of health and illness, you can imagine that we have some genetic factors that are making us healthy. We have some that may be contributing to increased risk for illness. Now, on top of that, we have lots of different factors. What we eat, what we drink, our exercise. Notice I put just one small glass of wine on the healthy side versus a couple barrels of beer on the other. Sorry to Dunkin' Donuts. But all of these things combined together contribute to whether we ultimately are healthy or not. For very few of us, this genetic piece could be the more sizable, excuse me, than these other risk factors. And so we're really talking about what is the weightiest or most significant risk factor. And so most of the time, cancer has a little bit of genetic risk that might be at stake here or at play. A few cases, we think roughly maybe 5% of all cancers may have a strong genetic component. Okay, and this is what I mean by all cancers begin with genetic mutations. And it's a great analogy because we often talk about it as the snowball effect. And for those of you that are still coming out of Snowmageddon, this might be appropriate. But if you think about it, our cells are supposed to copy themselves over, divide. That keeps us young. That's a good thing. We want that to happen. But it needs to be very, very well controlled. And so we have lots of genes whose role in our body is to control that division process. Those genes often get called cancer genes. They don't cause cancer. When they're doing their job is to control the mechanisms that could lead to cancer. It's when they're not doing their jobs that a cancer could develop. And so here you're looking at if we start off with normal cells, and then I have these little blast things here that look like an explosion, that's showing a mutation. I have lots of freckles, you might be able to see that. And so I say the sun obviously caused some genetic changes in my skin. So there's lots of things that can cause these genetic mutations, and our cells gather these throughout our lifetime. If that mistake is not caught by a lot of these other genes that do everything from typos to correcting mistakes, then it could be passed on to the next generation. And then additional mistakes could happen. And it's that accumulation of mistakes over time that eventually leads to the tumor development. A tumor development, you could kind of think of it as our normal cells, which have lost the control mechanisms that keep it well contained. So it's growing out of control. And so mutations that cause here at the bottom you can say mutations in genes that control growth and division can cause cancer. We call those, some of these are called tumor suppressor genes. So you can imagine they're ones that slow down cell growth. Some things are called mismatch repair genes. They do exactly what they sound like. They fix typos when the DNA doesn't match up quite right. So again, all cancers are genetic. They're caused by genetic mistakes. But most cancers are not caused by an inherited genetic mistake. The genetics of the tumor or the cancer are unique to that cancer and do not necessarily represent the genetics of the normal cells. That's the difference between what we call tumor genetics versus inherited genetics. And I'm going to go into that a little bit more. Some not too jargony terms, but somatic versus germline. Somatic testing is the genetics of the cancer cells. So that's that accumulation of mistakes that happen to create that tumor. The testing in these cells is often used for treatment decisions for that cancer. So they're looking for, they'll call it driver mutations, or the certain signatures of that cancer. And that's a lot of oncologists or surgeons may talk about using it. You may have heard Oncotype or Foundation Medicine. They have tests that are specific to this where they're looking at what characterizes that particular cancer or that tumor to then be able to find the most effective treatment for it. Occasionally, that tumor testing or somatic testing can give us a hint or a clue that there's a mutation there that might be present in the person's entire body that's not just specific to that cancer. Those are germline mutations. Germline mutations are the genetic code that we inherited from our parents and that we can then pass on to our children. And so that's a germ cell, you may remember back from biology classes, that refers to egg and sperm cells. And so testing for inherited mutations, we're looking at the germ cell or that genetic code. And so that can tell us, is there a risk to develop cancer that's being passed down in the family? Genetics that you inherit, or germline genetics, typically do not change unless it's specific, such as these, I described these genetic mistakes we accumulate over our lifetime. For the most part, those only affect a small sample of our cells at any given time. And so just to compare the two, at the top we're showing sporadic, which is what most cancer is, versus a hereditary risk. So you can see in sporadic, and these are supposed to be two little pictures of chromosomes that, I found my mouse here, that if someone is born with no inherited gene changes that cause a cancer risk, that over time they might develop a mistake or a genetic mutation in one of these important cancer control genes. And then over time, they might develop additional mistakes which eventually lead to a cancer. Typically, it's a later onset cancer, so later age of onset. And the cancers that are more common are ones that have more exposure. And so if you think about what tissues or organs in your body are exposed to the most, I guess, lifetime abuse or environmental abuse, it would be your skin, organs like your lungs, anything within your GI tract or your epithelial tract, bladder, kidney, things like that that filter out the bad stuff. Those are the organs that often are the most common forms of cancer that you see in a population, but the sporadic versions are later onset. You contrast that down here to our hereditary example. This is somebody who is born with a genetic change in one of their copies of their genes. So we have two copies of every gene in our body, one we get from mom, one we get from dad. And so often these are things that run on just one side of the family or the other. This individual is not born with a cancer. It still takes time to develop additional mutations to develop that cancer, but the timeline is significantly shortened. So one of the hallmarks of hereditary cancer is a much earlier age of onset. And typically it's in what I call target tissues depending on the gene involved. And so these could be organs where cancer is much more rare, and certainly the age of onset is much earlier than typical. Okay. So special note is that, again, as I say, tumor testing may identify variants that look germline. Typically this is based on what they call the allele fraction or the percent of cells that have a certain variant. Depending on that lab, it may or may not be noted on the report. Tumor testing is certainly not created or it's not developed to tell us information about inherited risk. And so if a patient says they've had a genetic test, it's important to ask and dig a little bit deeper to find out what kind of test it was, how their doctor used it. Like, did they use it to decide if they needed chemo or not? Or was it something to see if they needed, or we're going to recommend bilateral mastectomy or not? And that can give you some clues as to whether they were looking at inherited risk versus information about that particular cancer and treatment options. Okay, so now turning to our focus more on the hereditary part of this. Again, these are some of the hallmarks or some of the red flags that we see with inherited cancer risk. Multiple relatives with related cancers or the same type of cancer. Because depending on the gene, that gene may be more involved or have a more important role in certain tissues. Good example is the BRCA genes. We know that they are heavily involved in estrogen-related tissues, and thus the cancers we see most often associated with those genes when they're not working are breast and ovarian. Earlier ages of diagnosis, there's no specific cutoff here. We kind of use a broad sample of age 50 or less than age 50. Depending on how common that cancer is, sometimes the age is less than age 45 or less than age 40. But again, that's not a hard line. Multiple diagnoses in the same person. Now, this doesn't mean a metastasis, but actually a new primary cancer. Sometimes we can tell this by just the time frame, so how long it was between the first cancer and the second, or if it's in a different organ tissue. Very rare cancers, such as male breast cancer, which is exceedingly rare in the general population, doesn't mean that all male breast cancer is related to an underlying hereditary risk, but it's certainly something that's worth investigating. Or if you see cancer being seemingly, I say, passed down from generation to generation, people may not have the best records about family history, especially once you get several generations back, but there's often family stories about everyone had cancer, or no one had cancer, or maybe they all developed more exposure-related cancers, and they either worked all on a farm and had a lot of agrarian exposures, or they worked in coal mines or in factories, and so there can be some other lifestyle-type factors that are involved. Also, certain ethnic groups, we know more about their risk for particular genetic mutations. And I list here the Ashkenazi Jewish ancestry group. This particular group of people have been heavily involved in a lot of genetic research in the past, and so we know that about 1 in 40 individuals that are of Ashkenazi Jewish background carry a BRCA 1 or 2 mutation. And that's much higher than what we think the carrier risk is for other populations. So sometimes just knowing your ancestral background can give you a clue as well. And then a little bit of biology, and you may remember your Punnett squares. So most of the time, cancer risk is inherited in what we call an autosomal dominant manner. Autosomal just means the risk itself is equally passed down between men and women, and that each child of someone who has the cancer mutation or has the cancer risk has a 50-50 chance of also inheriting that particular mutation. You'll usually see multiple relatives affected in each generation, but what's important to know is that negative family history is also important. So if someone comes from a very large family, there's 10 siblings, having 2 individuals with related cancers may not be that unusual. You have to think about how much cancer you would expect to see based on the number of siblings. And I say here how many relatives were available that could have developed cancer. Sometimes a patient's an only child. Sometimes they could be an adoptee. Or it could be they came from a family where there was a lot of early death from unrelated causes. Motor vehicle accidents, fighting in a war, or other traumatic exposures, or even just early illness. And so that's such that there's not many people in that family who lived to a late adult age that we think would have developed or had the opportunity to develop a cancer if they'd lived long enough. In addition, some cancers are sex limited. Again, mentioning BRCA 1 and 2, just because those are ones that most people are familiar with. that although men do have breasts, even if they have a BRCA1 or 2 mutation, their lifetime risk of developing breast cancer is still quite low. Men do not have ovaries. So a BRCA1 or 2 mutation could be passed down for many generations through male relatives, and thus your patient doesn't have a family history of cancer because it's been hidden in relatives who have a lower lifetime risk. So the key point here is this last one, that the risk to develop a cancer is rarely 100% in anybody that has a mutation. And so simply having one of these mutations doesn't mean you're going to develop cancer. All right, so I'm going to start off with a couple of organ-specific examples. Breast cancer, as probably many of you know, is the second most common cancer in women in the U.S. There's about a 1 in 8 or 12% lifetime risk for women in the U.S. And that for those individuals who said that most cancer is inherited, this first statistic shows you that you're somewhat right. You could argue it anyway. That simply having a first-degree relative with breast cancer would increase a woman's risk about 1.5 to 2-fold above their population risk. Okay? And so that's looking at all the other familial factors, not necessarily things like BRCA mutations. And a first-degree relative, I'll show you a family tree in just a second. It means people that you're directly related to, that you don't have to go through another relative. So that'd be your children, your siblings, or your parents. In order to be related to your aunt, you normally go through a parent. So that would be your second degree. Hopefully that makes sense. Most breast cancer is sporadic, meaning that it's due to these lifetime accumulation of mistakes or things that we're not really sure what causes it. Something that's important is because breast cancer is so common, it's possible there could be more than one sporadic breast cancer case in the same family. And there can be a mixture of both sporadic and hereditary cases in the same family, which can make it very complicated. General screening begins at age 40 here in the U.S., but there's been some studies that age might be going back a little bit. So just to give us some pie charts, we say that about 5 to 10% of breast cancer is due to an inherited mutation in a gene. An additional 15 to 20% might be due to some familial risk factors. So you can see there's slightly more breast cancer than we'd expect in that family. We think there may be some lower genetic contributors at play here. Ovarian cancer, on the other hand, has a much higher hereditary component. That studies have shown anywhere from 12 to 20% of all invasive ovarian cancers, those women have an underlying genetic, inherited gene mutation that caused their ovarian cancer. Right now, the recommendation is any woman with any invasive ovarian cancer should be referred for genetic testing. So when we, again, I mentioned the BRCA1 and 2 genes a couple times here, and that's just because they're the ones you'll probably, if you get any questions from patients, it might be about these 2 genes. Angelina Jolie made them very famous a couple years ago. I tend to call them BRCA1 and 2 because I've just been in the field for a little bit. Patients or others will call them BRCA or the BRCA genes. The frequency in the population, number's a little bit in flux. It's between 1 in 200 to 1 in 500. In some populations, it's more common. As we mentioned, the Ashkenazi Jewish population is about 1 in 40. And they've even seen in some populations a study out of kind of central Pennsylvania, where there's a lot of Pennsylvania Dutch, but individuals who didn't know of any Jewish ancestry, they're seeing about 1 in 100 or 1% population frequency. But even with the lower frequency, we think there could be over 250,000 women in the U.S. who are carriers. And so that's a lot of women with a pretty significant increase in risk. And this is what we mean by that increase in risk. That these curves here, as you can see, that the increase, this is cumulative risk, these are percentages, so that by age 40, having a BRCA1 or 2 mutation, you have about a 20% or 1 in 5 chance of developing breast cancer by age 40. And then that number really, really spikes up after that. They estimate that it might be up to an 80% lifetime chance to develop breast cancer. Again, that number is not 100. So if we just think about that number, that's a 20% or 1 in 5 women who have one of these mutations live their entire life and never develop breast cancer, but they can pass that risk on to all of their children. Something that's really important, you heard me mention that a surgeon might want to know about hereditary cancer to help guide how they want to treat this initial cancer. So this is beyond the tumor testing, which would be that Oncotype DX score or Foundation Medicine score or whatever other test that they might use. This is looking at germline testing because that individuals who have conservative or breast conservative therapy versus having a kind of more significant mastectomy, there's up to a 70% risk of a second breast cancer in that same breast, either a recurrence or a new primary. And so this is looking at either the ipsilateral or contralateral of a second breast cancer. And so some surgeons will choose to be more aggressive in treatment, some patients as well. In the U.S., the rate of doing preventative prophylactic mastectomy is much higher than other countries, and it still remains a very personal decision, often based on that individual patient's, their experience with that first breast cancer, as well as the experience of whether breast cancer is something that kills all the women in their family or their close associates, or something that the women, they just deal with it and they, go through their chemo and they just go on with their life. That's a very personal decision, and everyone's experience of cancer is very different. All right, just a couple more statistics. None of these you need to really remember, but just know that these are some cancers that we see more frequently with BRCA1 and 2. And again, comparing individuals that were carriers of either a BRCA1 or a BRCA2 mutation, what their lifetime risk is, compared to the general population. And so you can say again here, we mentioned male breast cancer in the general population is that 0.1 or about 1 in 1,000, whereas with BRCA2 we think it's a 5 to 10% lifetime risk. So significantly elevated, though still most men who have a BRCA2 mutation do not develop breast cancer. Other cancers that we do see that are elevated are pancreatic, as well as prostate. Melanoma is still, I think it's a little controversial as to how elevated it is. And again, none of these reach 100%. Knowing that the patient has one of these mutations doesn't tell us that they have cancer, just that they have increased risks and how we need to guide their surveillance. Okay, so what do? There's increased surveillance. We want them to consider chemoprevention and also consider prophylactic surgeries. So just to go over these briefly, the most effective way to reduce risk in a BRCA carrier is prophylactic bilateral mastectomy. We know it reduces breast cancer risk by greater than 90%. We also have learned that prophylactic oophorectomy, if it's done prior to menopause age, it can reduce both the risk of ovarian cancer by about 95%, but also can further reduce the risk of breast cancer. So this, because it's, again, about estrogen exposure as a main contributing factor. Current recommendations for screening, because again, not all women at that point in time in their life are ready for prophylactic mastectomy, and again, it's a very personal decision. Some women choose to wait until after childbearing or any nursing, or some women actually choose to wait until that first breast cancer because they say, maybe I'll never develop it. And what's the point of a prophylactic mastectomy is a pretty involved surgery if they never develop the cancer. So the recommendations for enhanced screening are monthly breast self-exams beginning by late teenage years, then early clinical surveillance beginning in between 20 and 25. Younger women have denser breast, and so it's recommended that they get both annual mammography as well as breast MRI. We normally schedule those so that every 6 months they're getting one or the other. For ovarian cancer, there's no really good screening options. People have looked at the CA-125 blood levels. You guys may be familiar with testing those in women who have ovarian cancer. It can be a good marker to follow people who have cancer, but it's the evidence out there shows that it has a lot of false positives and false negatives when you're trying to use it as a screening test. Some women will do that just to have something. They just regular gynecologic exam, maybe doing a transvaginal ultrasound, but the recommendation is that most women who are carriers consider having their ovaries removed prior to age 40 if you're a BRCA1 mutation carrier, or age 45 for BRCA2. So identifying high-risk families. And I laugh at this because sometimes genetic counselors get compared to fortune tellers. And I always say, well, we're not really going to be able to tell you what's going to happen in the family. And with patients, I say I can never answer that big why did this happen question. That's beyond me. But we can talk a lot about risk factors and what's the chance that something could happen, as well as empower that family with some tools so that they can take advantage of that knowledge. They can't change whether or not they have a mutation. What they can change is what they do with that information. So the patterns that we search for in families are, again, the number of people who are affected, how they're related, the ages at which they're diagnosed, what are some of the other risk factors, and a really important question is who is the most informative person to test. Because sometimes the patient sitting in front of you isn't the best first person in that family to test. Okay, and I'll talk a little bit more about why that is. And again, this is our group here. I was missing one picture. I'm going to track her down. Of Beth Hudson, but we're growing. We have 7 genetic counselors and 3 medical geneticists, and this is ways to track us down. You can always give us a phone consult if you have a question about a patient or if you want some more information. Feel free to call us. So, what do genetic counselors typically do in a session? One is explore some of these personal and family medical histories. We also go into their risk perception, motivation, why they want testing. Again, I said there's a lot of differences in how that patient may think about that cancer or the risk to develop a cancer. There's some education involved, both basic genetics and inheritance patterns, as well as what we mean by cancer genetics and risk. You may have been exposed to, or you've heard, or your family may have similar stories of inheritance patterns that get created by patients. They talk about things that skip generations, things that only affect people who look alike in a family. And so recognizing that families try to create ways to explain what they've seen, which may not always be true. And so there is a little bit of education involved, but also being very aware of what that family's experience is and what their knowledge is based on coming into the room. We also want to discuss and personalize a lot of this information, whether it's risks, so cancer risks or other health risks, the benefits and limitations of testing, what that procedure is like. Usually it's just a blood test. Are there alternatives to testing? So what will we do if we don't test? How would we treat them any differently? And what are the management options? So this is a basic family tree or pedigree. You guys may have seen these before, or you've always wondered what these different lines mean. And here, this is just, when you draw a line directly, a horizontal line between people, that's a mating line. And so a big mistake I sometimes see folks do is they end up mating siblings by accident. Okay, this down here is a sibling line where they're all dropping down from one line, and again, mating line. So if you do this right here, you've just married these 2 sisters. All right, if you see a double line right here, that actually means a consanguineous mating. So it could be between cousins or further related. In genetics, this typically the fact, whether 2 individuals are related or not that have children, mostly comes into play with recessive conditions, not typically dominant conditions. Again, these are, so this individual had children with 2 different partners, and so we can kind of make little spokes of our wheel out here and just keep drawing down our people. Squares are males, circles are females, diamonds, either we don't know the sex or there are a lot of people and it wasn't important, so we'll just do a diamond. This line right here, so you're wondering, this means infertile. If there's just one of these 2 lines down here, that means no children. And you don't know whether they're infertile or they haven't had children yet. Okay. So this is the first of our pedigrees here. And if this were our 46-year-old patient to begin with, I've switched up her family history a little bit. She herself does not have cancer. Her mother had a breast cancer at age 70, so pretty late onset. But her maternal grandmother had 2 different breast cancers, both of which were pretty early onset, one of which was very early onset. In addition, another relative also related through this same grandmother is a cousin over here. Well, actually a first cousin once removed, in your genetic jargon speak, who also had a decently early onset breast cancer. So in this family, the best person to test is not your 46-year-old unaffected patient. It's her mother, because she's still living. Because we don't know whether this mother has inherited a genetic risk in the family, but hers just happened to happen at later age, or whether hers is a completely sporadic breast cancer unrelated to what appears to be a hereditary breast cancer in the family. So in order to get the best information about this family, this woman is the best to test. Okay? And so if we tested her, and we found out she's BRCA2 positive. All right, now we know what we're dealing with in the family. So now we can offer specific testing for that one mutation, not looking at a big panel of genes, that one mutation to anybody at risk. That could be to her brother. You could say, well, would we test her brother? Well, we may not need to test her brother. We could go directly to this young woman down here. We don't have any information about their children down here. There could be lots of females down here related to this male that this information is very important to. But you can see that once you know the information about the family, what the risk, what's causing the risk in the family, there can be a lot of additional individuals who require testing. Sometimes we call that cascade testing because even individuals over here also need to know this result. And so in this case, our patient did turn out to be BRCA2 positive. She's not had cancer yet, but that significantly changes how we want to manage her. Her sister was BRCA2 negative. Okay, here's another case. This patient, she's 39. She had breast cancer at age 36. She comes from a family where her mother also had breast cancer, and then there's a lot of individuals who are male or died young. Not a lot of extra females up here. So some people say, well, it's kind of a late onset. Statistically speaking, most likely this isn't hereditary, but it was very young. So in this case, our patient, well, first of all, her mother's no longer living, but she is the best person to test in the family because her cancer is both early onset as well as she has been affected by cancer. So in testing her in this family, we found out she is BRCA1 positive. Here's another case where our patient here was this 29-year-old who came in. She has not had breast cancer. Her mother had breast cancer at a very young age and died of that cancer. Her mother's not available for testing. So best case scenario, we would have wanted to test that mother, but she's not available. So in this case, we have to test the daughter. We find she's BRCA negative. Now, what's important to know is in her test, we call that, it's not as reassuring because we don't know, did we test for the right genes? So is there truly a hereditary cancer risk in the family that she didn't inherit, and that's why her test is normal? Or is there a hereditary risk in the family, but it's due to a gene we didn't test? Something else is that her negative result tells us nothing about her sister. Her sister still has the same increased risk that our patient had. And so we would have to test the sister as well in the same expanded panel that we'd probably test this first one. All right. And then I think this is our last example. This is a 36-year-old, and we test her, and she's BRCA negative. And so what is beyond BRCA1 and 2? Okay. And these are where we've gotten into a lot of larger panels, and some of you may be familiar with some of these different testing panels. But there's now greater than 20 different genes that have been associated with an increased risk for breast cancer, about 13, I think, to 16 with ovarian cancer to varying degrees. And depending on that family history, we may choose to test for additional genes. Not all of these genes get the same risk, lifetime risk of breast cancer. And so it can be a little complicated if you get a mutation in one of these genes to know how does that actually change the management. Now, the latest NCCN guidelines have started incorporating some of these genes in their management, which I think is really helpful. So if you have questions, definitely look there. This one paper showed that 67% of individuals who had a positive mutation on their testing, this is of 1,700 that were tested, 67% have a mutation in a gene other than BRCA1 and 2. So again, BRCA1 and 2 are certainly what we call the biggest players in terms of hereditary breast and ovarian cancer, but they're not the only ones. All right, and this is again a paper from ovarian cancer. This was showing that about 18% of all women with an invasive ovarian cancer had a hereditary gene mutation. And the genes here were 11 genes that they looked at. and there's been several more since then. This is what some of the different panel options can look like, and this is old. This one is from one company. There's about 3 or 4 different companies that offer this testing, and depending on the pattern we see in a family, we will decide which one we think is most appropriate and can give us the most informative result for that particular patient as well as their family. So, how do we decide what to order? Hopefully you guys have lunch instead of looking at a fast food menu. You don't think much about my health food choices. But some of the questions we ask is, how specific is the phenotype? And by phenotype, we're talking about the cancers we're seeing in that family. Some families, depending on the cancers we see, it's very specific to particular genes. That could be based on the type of colon polyp, for instance, or based on the pattern of those cancers. Also, how soon you need the answer. The larger the panel you order, the longer it's going to take to get that result. Medical insurance coverage. We'd like to think that that's not an issue, but it always is. Most genetic testing is covered, or most of the time we can find a way to get it covered. But sometimes that might limit which company we can send that particular patient sample to. And so just like those different menus, every insurance company has slightly different policies. One to remember is that Medicare, for example, will not cover genetic testing if that patient has not had cancer. If the patient has had cancer, it will cover the testing as long as they meet the criteria. Medicaid, unfortunately, Medicaid doesn't cover testing. However, there are several genetic testing companies which will accept samples and essentially offer that testing for free to Medicaid patients to ensure that they get access to this testing as well. So don't give up hope if you think that they cannot cover genetic testing. And if in doubt, you can always give one of us a call and we can help work you through the process. We also try to minimize learning unrelated information. Sometimes companies put genes on panels because it's easy for them just to add the genes on, even if they're not related at all to the type of cancer your patient has had. And so you might end up finding or getting a result that has nothing to do with why you ordered the test in the first place, and you're left with having a completely different discussion about risks with your patient. And so we try to minimize some of that when we choose which panels we order. All right, now let's talk a little bit about colon cancer. And you have all my slides, and so I apologize if I put too much information in here. I really want these slides to be a resource to you, so that way even beyond this talk, if you need to go back and look at something, hopefully there'll be some little tools in there you can use. So colon cancer is the 3rd most common cancer in U.S. men and women. The lifetime risk is about 1 in 20 or 5%. So it, for some reason, doesn't get as much attention as breast cancer. I think that doesn't have as strong advocates. But first-degree relatives of someone who's had colon cancer can have a 2 to 3-fold increase in their lifetime risk for colon cancer, so it's very important. Colon cancer often begins as a polyp in the lining of the colon, and general screening is recommended to begin at age 50, and there's a couple of different mechanisms for general screening. Now, hereditary colon cancer accounts, similar to the pie for the breast cancer, accounts for a small percentage of the total amount of colon cancer. Most of hereditary colon cancer is due to a condition we call Lynch Syndrome. Now, Lynch Syndrome was named after a Dr. Lynch. Why you'd want to have any genetic syndrome named after you, I don't know. But it used to be called Hereditary Non-Polyposis Colorectal Cancer, or HNPCC. Besides being a really long acronym, a major cancer for this particular syndrome is endometrial. And so they felt that the misnomer was actually leading some patients to be missed. And so now they've gone back to calling it Lynch syndrome. There's also other names because other doctors described other parts of the Lynch syndrome spectrum. And so don't be surprised if it's the same thing or the same genes and they might give it a slightly different name. But most people call it Lynch. And down here you can see that Lynch syndrome accounts for 2% of all endometrial cancers. And so that's something that people frequently don't realize, that colon cancer and endometrial or uterine cancer can be related. All right, so this particular study was among 450 patients with an early onset colon cancer. So again, they used a cutoff of 50, that there were 75 mutations. We call them pathogenic or likely pathogenic. That just means that they're ones that are known to be cancer risk causing. So about 16%, or 1 in 6, had a genetic mutation. And so if you think about that, of all your colorectal cancer patients that are under age 50, about 1 in 6 of them could have one of these mutations. And about half of those had Lynch syndrome. So what is Lynch syndrome? Again, it's a dominant cancer risk. There's 5 genes, these MLH1, MSH2, MSH6, PMS2, and EpCAM, all being related. The 2 main cancers are colon and endometrial. These genes are called mismatch repair. And what's unique to Lynch syndrome is that tumor pathology, so on the actual pathology report, there's testing that is recommended in all colon cancers that can give you indications of whether that particular patient may have Lynch syndrome or not. And I'll talk about those. So with Lynch syndrome, typically the cancers, rather than being here in the more distal end of the colon, are further in. And so that's what makes it unique, that most sporadic tumors, or the majority of sporadic tumors, can be here more closer towards the rectum, whereas it's in the proximal site of the colon in 2/3 of Lynch syndrome. The age at diagnosis, they say earlier, can be around 45 years of age, but I've seen the full spectrum. I have a patient who was diagnosed at age 15. Her father, who was also a carrier, was unaffected, and it was really her grandfather was the only other colon cancer case in the family, and his diagnosis was in his late 50s. No one would have thought that family was a Lynch syndrome family. And so we can still be surprised by these families when the family history doesn't show us a pattern that looks suspicious. The cancer risks over lifetime, so similar to breast cancer, they start to spike closer to that age 40. So the lifetime risk of colorectal cancer, we think, goes up to about 80%, endometrial cancer around 60%, other kind of GI tract cancers can be anywhere from 10 to 20%. Ovarian cancer also is elevated up to about 10 to 12%. So sometimes when you see ovarian cancer, you need to try to figure out whether this could be a Lynch syndrome related ovarian cancer or a BRCA or other ovarian cancer related condition. So this is just another look at some of these different lifetime risks. It varies by gene pretty significantly for Lynch syndrome. You don't need to remember these, but just know that different Lynch syndrome genes may have vastly different lifetime cancer risks. PMS2 having a much lower colon cancer risk, as well as endometrial cancer risk compared to the others. And this is a family to show here, just to give a good example. Our patient was 28 years of age with colon cancer, so of course they got brought to attention. If you notice, there's not really much family history on either side. Mother died young with a stroke or heart, which, let me just say, that's a very early onset for especially heart disease in a female. So he might have some other risk factors for heart disease also involved here he should talk about. But we did do testing, and he was MSH1 positive. Here's another family, and for the interest of time, I went ahead and told you what it was. Although our patient came in age 50 with no cancer, again, trying to find the best person in the family to start out testing, we learned that she had a brother who had colon cancer at age 40. We thought that sounds suspicious, but this colorectal cancer at age 30 was the most suspicious, and this niece had testing which was positive and provided an informative test for the rest of the family. Tested our patient after the fact, and she was also MSH2 positive. And again, showing the 50-50 chance. Doesn't always work out this clear, but it is a 50-50 chance for an autosomal dominant condition with every child that resets. All children could inherit it. All children might not. Any family member who doesn't inherit the known mutation in the family, they cannot pass it on. Can't skip generations. All right, so this is the tumor testing I was talking about. It's called universal screening for Lynch syndrome, and it's recommended that all colorectal cancers, different centers have different age cutoffs, but they should go through some version of this universal screening. Frequently it involves the microsatellite testing or MSI testing. So if it's MSI high or microsatellite instability, if it has a high amount of that, usually there's a certain number of markers they test, that can be an indicator of possible Lynch syndrome. Frequently, if a tumor is MSI high, then they'll reflex to IHC. that immunohistocompatibility testing. And in that one, you're looking for the absence of a signal. I've sometimes had people call me up going, oh my goodness, my patient is positive for all of the Lynch syndrome genes on their IHC test. If they're positive for all of them on this, that means that they showed the protein signal. That's a good thing. That means the proteins were doing what they're supposed to be, and it's most likely not Lynch. Lastly, there's something called MLH1 promoter methylation. That's the third tier of testing, or sometimes they'll do BRAF testing. That is if it's MSI high, if the IHC shows that there's an absence of MLH1, then they'll do this promoter methylation. That's kind of like the last test to see whether it looks like it's more sporadic or possibly a hereditary cancer. The good news is that even if it's not Lynch, tumors that have MSI high tend to actually be better, more favorable as far as treatment they're finding. All right, so Lynch syndrome screening guidelines. If someone is known to have one of these hereditary mutations, or if they have a family history that looks very much like a Lynch syndrome family history, we recommend colonoscopy beginning between age 20 and 25. Doing colonoscopy every 1 to 2 years. We prefer to do it annually. And then you remove any precancerous polyps. A colectomy is a last resort. Also consider a daily aspirin as a preventative. Some early studies have shown that it may reduce the colon cancer risk by as much as 50%. For the gynecological cancer screening, again, there's no good ovarian cancer screening, so we do recommend that patients consider oophorectomy after childbearing. Endometrial biopsy, we recommend every 6 months with annual exam as well as transvaginal ultrasound, beginning around age 25 to 30. And then, of course, for the upper GI or urinary tract, we'd recommend an upper endoscopy. There's not great guidelines for when to begin that around age 30, and then perhaps once every 3 to 5 years based on what's seen. For the urinary tract cancers, we recommend annual urinalysis beginning again between age 25 and 30. All right, we don't have much time, but don't want to forget polyps, and hopefully you've already had lunch. But when we talk about a lot of polyps, we mean a lot of polyps. This is familial adenomatous polyposis, or FAP. Individuals with this particular condition truly do have an almost 100% risk of colon cancer, usually by age 40. So this is a very early onset. It's a pretty drastic look when you image on the scope. What's interesting about this particular condition is that up to 30% of patients have what we call a de novo mutation. De novo means it happened for the first time in them. There's no family history. And so these individuals, unfortunately, don't have the benefit of any pattern to be able to tell them there could be a risk. Usually they're the first persons in their family to present. And then if testing can find a mutation in them, then there's cascade screening of all of their children or other relatives for the future generations. But for them, hopefully, they have early symptoms and can catch it. Sometimes there are early symptoms, unfortunately not all the time. The gene responsible is this APC gene, and it can have both the classic form or something called an attenuated form. The attenuated form is just much more mild. Lastly, there's a form of polyposis due to MUTYH. This one's unique, and the one thing to remember about this, it's recessive. And so in this case, it does require mutation that it's inherited from both parents. And so similar to things that are recessive, such as sickle cell or cystic fibrosis, often you'll have multiple individuals who are affected that are siblings, but you normally don't see generation to generation. About 3% of people of European descent are carriers, so it's not unlikely to have someone who's affected ends up marrying or having a child with someone who's also a carrier. And so you can have that generational passed down, but it's not as likely. All right, so I'm going to skip forward a little bit. Screening for this, there is a hepatoblastoma screening that's recommended very early from birth to age 5, and then sigmoidoscopy or colonoscopy beginning in between 10 to 12 years of age, followed by colonoscopy once polyps are detected. Typically, especially in individuals who have a very large polyp burden, they do end up with some form of colectomy. And then upper endoscopy as well as any scoping of a pouch, just to be able to evaluate those. Thyroid cancer is also seen more frequently in individuals with this particular syndrome, FAP, and so they recommend annual thyroid exam. All right, so I'm going to skip through this since we talked a little bit about the MUTYH. It's milder. It's more like the attenuated form. And so genetic testing. Again, our clues, as we've been talking about, multiple affected individuals, early age of diagnosis, multiple primaries, something that's an unusual or a rare cancer, some ancestries are things that we'd want to look for. Clinical testing is available for most family cancer syndromes. It's best to test the affected individual if possible. Cost varies, but most insurance do cover genetic testing. There can be specific criteria. And then what do? There is a purpose for doing it, and it could be very helpful for families. If we find a risk, there's increased surveillance. There may be chemoprevention to help prevent a cancer from developing, or prophylactic surgeries. Genetic evaluation and testing can help guide decisions about current cancer management as well as prophylactic surgeries. Family members may find they haven't inherited the risk and it can avoid some unnecessary screening. In some families, even knowing what you're dealing with can provide relief and gives you less uncertainty, and families can plan. So this very last thing in our final little bit, I apologize, people may be worried about genetic discrimination. There's legislation which has been on the books for quite a while that prevents employers or your health insurers from using genetic information to discriminate against you. Unfortunately, that doesn't apply to life insurance or disability. All right, so that's just that. These are some final resources. Again, you have all these. And these last little bit, I didn't mean to go over them at all, so they were always here for extra resources. And that's it.
Great. Thank you so much. This has been tremendous. I want to go ahead and advance and see if we have any questions. Again, you can go ahead and go to, you can text, if you haven't already, the letters UNCCN to the number 22333, and then you can go ahead and submit questions, and we'll see if we have any that have shown up already. Not yet, but while we're waiting for those questions to come in, let me ask you, we talked about the company you've been involved with, Illumina, in the past. I know there's 23andMe and other companies as well. What's the pace at which this is advancing, and at what point do you talked about the price considerations for testing and whether insurance will cover it? At what point does it get to be really not an option not to test, and when do we get to be that efficient? And I guess also when we look at something like that $100 test that Illumina is targeting, is that comprehensive of all the things you've talked about here?
And so it depends, and that's where it's really important to know what's included in the test. So tests like 23andMe, they do not look at most of these hereditary cancer genes. They're looking at things that are more familial risk. We call them, they're kind of complicated or multifactorial risks. And so they may slightly increase someone's lifetime chance, but not that you do any medical decision making on it. But other companies, there are some that are in between. There's one company that offers their testing and they don't bill insurance, and so because of that, they get around some of the costs of testing that just go with that. They're high informatics. Google was part of there, and you can get testing for about 25 genes if you're willing to pay $250 out of pocket. So it's certainly going down. People are doing research. We're doing some research here at UNC about doing population screening, a program called Gene Screen, which individuals who are part of the UNC family medicine practice might have seen that. Okay.
All right. We have a question. We have a thank you for the great presentation. After that, what does what dose of daily aspirin is being used for prevention of colon cancer?
And that's where there's not good guidelines. The GI clinician I work with, Dr. Bob Sandler, he will recommend either a daily baby aspirin, but I think it's important that because there's not good guidelines on exactly what that dose is, that you need to consider that patients kind of holistically. Are there other indications that would be contraindicated for aspirin use? But right now, at least the preliminary stuff shows that it could be really beneficial.
All right, very good. And is there a way to get a copy of the presentation slides? Absolutely. Just go ahead and email us at unccn@unc.edu, and we can we'll be happy to show you how to get those. Those should generally be available already, but if you have any trouble with that, we'll be happy to assist with that. I want to thank everyone again for attending, and thank you so much for presenting. A couple of things just to go over before we leave. January 25th, our Med-Surg lecture, Sickle Cell Disease, an overview and updates with Dr. Ataga. On the 27th, also at noon, Community Lunch and Learn lecture on Cancer Clinical Trials 101 with Ms. Kim Keller. And then on February 8th, RN and Allied Health lecture, Late Effects of Cancer Treatment, Managing Cardiac Toxicity with Dr. Jensen. So we hope you'll be able to attend some or all of those. We want to thank the state of North Carolina and their generous support of the UCRF, which makes this all possible. We want to acknowledge the UNC Lineberger Comprehensive Cancer Center and specifically call out Mary King, Max Gaynor, and Alan Brown on our team who make this all possible. Thanks to all of them. We hope that you have a great afternoon, and we look forward to seeing you soon. Thank you so much.